Welcome to Paediatric Orthopaedics for medical students. My name's Anna Bridgens and I'm a children's orthopaedic consultant at St George's Hospital. The medical licensing assessment has highlighted key areas in paediatric orthopaedics which we will cover in this lecture, and they're outlined in this table under presentations and conditions. So I've started the lecture with non-accidental injury. The reason why I've put this first is because it is something that I would like you to always bear in mind when you're reviewing a child in A&E that presents with an injury. There are key points in the history and an examination which might raise your suspicion of NAI. In the history, you might find that the child has had a delayed presentation, that they're already known to social services, that they have had lots of previous A&E attendances. Sometimes the story may not be consistent, that the parents keep changing the timeline of what happened or how the injury happened. And then in the examination, you may find that the interaction with the child is slightly strained. The child may look unkempt. You should always fully undress the child and look for other signs of injury such as bruising and burns. And particularly if the child isn't yet walking, so a fracture in a child that is not yet ambulant is always a cause for concern. There are specific types of fractures that we worry about. Metaphyseal corner fractures in all children, but particularly non-ambulatory children, rib fractures, and fractures that are at different stages of healing. And if you have any concern regarding this, you always need to notify the paediatric team, and you should complete something that called a body map, where you document where you found different injuries. This slide just shows some x-rays of the typical fracture patterns in non-accidental injury. The picture on the left of your screen as you look at it shows an adult putting longitudinal traction on the limb with the twisting causing metaphyseal corner fractures, and the next two x-rays along show a medial proximal tibial metaphyseal corner fracture, and the one below it is a distal femoral metaphyseal corner fractures, both medial and lateral. And then finally, we have a spiral femoral fracture in an infant. So this is always concerning because the child's not yet walking. And below that are rib fractures in different stages of healing. So all of these children would require notification to the paediatric team. They should immediately be admitted and safeguarding investigations started. This leads us on to the next topic of discussion, which is fractures in children. When describing fractures, it's always helpful to say which part of the bone is affected. Now, I'm sure you will have covered this in adult trauma sections of your curriculum. There are some small differences with the paediatric bone, which I want to highlight. You still have your diaphysis, which is the shaft of the bone, and then above and below that, you have your metaphysis, which is the wider portion of the bone, which tends to be slightly softer cancellous bone. But just adjacent to the metaphysis, you have your physis, your growth plate, and then above or below the physis, depending which end of the bone you're looking at, you have your epiphysis. And it's important to be aware of these areas because if a fracture is extending or involves the physis, this can cause problems with the growth of the bone long term. I put these x-rays in to show the difference between a paediatric x-ray and an adult x-ray. So if we start top left as you look at the screen, you have a paediatric hand x-ray, and you can see that some of the carpal bones cannot be seen on an x-ray because at this point they're still cartilaginous and they don't show up on x-ray. And as the child grows and enters adulthood, these bones ossify, the cartilage ossifies, and you are then able to see them on the radiographs. You can also see that the growth plate has closed, and then below that you have a tibia and fibula, and you can see that you have your diaphyseal shaft, and then as it extends into the metaphysis proximally and distally, you then have your physis and then your epiphysis. But if you look at the adult radiograph of the tibia and fibula, you can see that there is the diaphysis, which just goes straight into the metaphysis with no physis. That physis is closed. And similarly, the long leg alignment views of the child and the adult. So fracture pattern and the type of fracture. So these are just a few buzzwords that we can put into describing a fracture that can help convey the type of injury the child has had. So first of all, a complete fracture all the way through the bone, and that can be transverse, oblique, spiral or comminuted. And comminuted means that there are more than two parts to the fracture. And then we can have an incomplete fracture, and this is when the whole cortex has not been broken. And this is more common in children because they have a thicker periosteum along the outside of the bone. And it can just be bowed. This particularly can happen in a forearm fracture where one bone breaks. So the radius, for example, could break and we just get some bowing of the ulna. We can get a buccal fracture, which is a fracture on the concave surface of the bone, or a green sticks fracture, which is a fracture of the convex surface. And then we have this term Salter-Harris, which is a fracture that involves the growth plate. The Salter-Harris classification was named after these two gentlemen, Bob Salter and William Harris. And the Salter-Harris classification gives us an idea of how severe the damage has been to the physis and a prediction of prognosis in the future. This mnemonic helps us remember the type of Salter-Harris injury it is, and it goes from 1 to 5, though there have been some additions to the original classification over time. But you can see 1 is just a mild injury through the growth plate, but at 5 it is a much more significant crush injury, and you're much more likely to get a growth arrest in a Salter-Harris 5 injury. Salter-Harris 2s tend to be very common, particularly around the distal radius. We've talked about the location of the fracture. We've talked about the type of fracture, whether it's complete or incomplete. And finally, we're going to talk about fracture displacement. So the fracture can be angulated, translated, rotated, and shortened. Angulation and translation and shortening can remodel well, depending on the age of the child and where the fracture is in the bone, but rotation doesn't remodel. If you have a fracture near the growth plate in the plane of movement and the child is younger, you can accept a lot more displacement than in an older child in a mid-forearm fracture. This child has had a mid-diaphyseal transverse femoral fracture with some shortening. Now, this will remodel very well. We can see it's a young child. The growth plates are open still, but there is quite a significant shortening here. But I'm not particularly worried about that, because for every femoral fracture that you get, you tend to get 1.5 centimeters of overgrowth because of the blood supply and the healing. So I know that though initially this leg will look shorter, it will have increased growth compared with the other side, and it will catch up. This series of x-rays shows a Salter-Harris 2 fracture of the distal radius, and it's a sequential x-rays in different stages of healing, and you can see how this child has remodeled. It's likely in a younger child. It's through the growth plate and it's in the plane of movement. And though this hasn't been reduced or put back in the correct anatomical position, this child has completely remodeled. Another type of fracture is what's called a pathological fracture, and this is when a fracture occurs in abnormal bone. So whenever we're considering a fracture, we should always look to see if there is any signs of an underlying bone lesion. Is there a cyst present? Is there any evidence of osteopenia, particularly if the child is non-ambulant, has cerebral palsy or spina bifida? This can be a risk of fracture. Similarly, osteogenesis imperfecta, when children have a collagen disorder, puts them at high risk of fractures. Fractures in a child's elbow can be tricky. This is mainly because when a baby is born, the majority of the elbow growth plates are all still made of cartilage, and these ossify at different stages as the child grows, and therefore it can be difficult when a child has an injury to know if there is a fracture or whether the ossified part of the cartilage is actually just a normal part of their anatomy. So it really helps to know the order in which the cartilage turns to bone, and we use a mnemonic crittle for this, and I always remember it as 2, 4, 6, 8, 10 as a rough guide of when these bones appear. And the crittle stands for capitellum, radial head, internal, open brackets, medial, close brackets, epicondyle, trochlear, olecranon, and lateral epicondyle. And it additionally, which we'll cover in a minute, drawing lines on the x-rays can help. So let's look at crittle in a bit more detail. These x-rays on the right hand side of the slide, as you look at it, have the different bony landmarks highlighted. So at this stage, the cartilage has ossified, but the growth plates are still open. And you can appreciate if a child comes in with a swollen elbow, that some of these lines could be mistaken for fractures. So using the knowledge of when these bones ossify or appear, we can work out how old a child is. So if we look at the x-ray on the left hand side, I can see that the capitellum has appeared and it lines up with the radius, but the radial head ossification centre has not yet appeared. So I therefore know that this child is not yet 3 or 4. So I would estimate this child to be 1 or 2 years old. If you look at the x-ray next to that, you can see the capitellum, you can see the radius, and the radial head is there. So we know that this child is about 4 years old. And then if we look medially, I think I can just about see the medial head is the medial epicondyle has appeared, but there is no trochlea. So I know this child is around 6 years old. Other things that help when analysing elbow x-rays are knowing what lines to draw. We should draw a line. We can draw a line along the front of the humerus down into the capitellum, and that's called your anterior humeral line, and that should cross at the junction between the anterior third of the capitellum and the middle third of the capitellum. And you can see on these x-rays to the right, A, B, C and D, the anterior humeral line looks to be in the right position, but in B it's a little bit too anterior, and you can see as well there is something called a fat pad sign, a posterior fat pad sign, which is that slightly darker region behind the humerus and anterior to it, and this is a supracondylar fracture. It's quite subtle, but this anterior humeral line helps you because you can see that it's not quite passing through the capitellum at the right point. And C, you can see it completely misses the capitellum and is crossing in the radius. And there's also an anterior fat pad sign. The other line that is helpful is the radiocapitellar line, and that's a line along the radius which should intersect with the capitellum, and that's quite a helpful line when children have a dislocated radial head to help you pick that up. This is an example of how these lines can help you. So at first glance you might not think that there is anything wrong with this x-ray. You might notice that there is a proximal humeral fracture, which you can see a break in the cortex, and may think this just needs a plaster. But if you remember your radiocapitellar line and you draw a line along the radius, you can see that that does not intersect with the capitellum, and this radial head is dislocated. This child has required surgery, and actually by improving the position and alignment of the ulna, the radial head is now lining up nicely with the capitellum. And what you can also see in these x-rays is that this child has had some dye put into the elbow, which is radio-opaque, and it has highlighted the cartilage of the elbow joint, which isn't yet showing up on x-ray. So next is supracondylar fractures. These are very common in children around the age of 4 to 8 years old, and particularly common in the summer. And it's a fracture that occurs through the thinnest part of the distal humerus, just above the growth plate. 95% of these are hyperextension injuries, and we classify these using the Gartland classification. And a type 1 is undisplaced. A type 2 has some mild angulation, and if we think about our anterior humeral line in these, you can see that it doesn't pass through the capitellum, which is the distal part of the humerus. These tend to have a intact posterior cortex, and we can treat these with just a little bit of flexion in a plaster cast. The type 3s tend to be completely displaced and need surgery, and type 4s you really diagnose at the time of surgery, and they're very, very unstable, and the periosteum has been completely disrupted. The Gartland 3 and 4 types can lead to neurovascular injury because of the degree of displacement. And if you look at all the important clockwork that comes through the elbow joint down to the hand. You can see why this happens. Sometimes these children present without a pulse, and even in some cases an ischemic hand. And you can see how in that picture on the right hand side, the brachial artery is kinked over the fracture. So when these children come in, it's really important to check their pulses. If there's no pulse there, you need to check their perfusion to see what their capillary refill is, and always check the median, radial and ulnar nerves. And it's imperative to have this documented pre-operatively so that you know post-operatively what their status was, particularly if they have a deficit post-operatively. It's good to know what was present before surgery. A supracondylar fracture can cause a lot of swelling and bruising to the soft tissues. It's much easier to treat these nearer the time of injury than leaving them till the next day. You can see that the fractured humerus has what we call buttonholed through the brachialis muscle and has caused this bruising in the antecubital fossa. This can be quite difficult to reduce and will require significant amount of traction to get the bones realigned. So moving on to other types of fractures now. Unlike the elbow, the proximal humerus can tolerate a lot of shortening, angulation and translation. As you can see from this picture, this proximal humeral fracture has completely remodeled. These are two specific types of forearm fractures. One is called a Galeazzi fracture, and that is a fracture of the radius with a dislocation of the distal ulnar joint. You can see it's just standing up above the yellow arrow. And then on the picture on the right hand side is what we call a Monteggia fracture. And if you remember, you might think that this is just an ulnar fracture, but can you draw your radiocapitellar line? Where is that radial head pointing? It's not lining up to the capitellum. So there's a ulnar fracture with a dislocated radial head. Finally, lower limb fractures. These tend to be higher energy fractures and can have, because it's higher energy, they have a degree of soft tissue involvement, and we need to always be mindful of a compartment syndrome, particularly with a tibia fracture. The other thing to point out is that femoral neck fractures can have an impact on the blood supply to the femoral head, and these really need to be treated as an emergency in younger children because they can have catastrophic consequences and go on to avascular necrosis. Right, we're changing tact a little bit now, moving away from fractures to the limping child. Now, this is something that as a paediatric orthopaedic doctor, I get calls about very, very regularly. It's very common for a child to present to accident and emergency with a limp. And your differential diagnosis is going to really depend on the following points. First of all, you want to know the age of the child. Is the child in pain? Are they systematically unwell with a fever? Pertinent points in the history: recent viral infection, history of trauma, family history of any joint problems. And does it appear to be located to just one joint or any other joints painful? So let's break this down. Let's take the younger child, say 1 to 3. Not likely to be under 1 because the child's limping, so they need to be able to walk to limp. So is it painless or is it painful? Let's take the painful arm. Always high on my differentials is transient synovitis, because this is the most common cause of hip pain in the paediatric population. But it should always be a diagnosis of exclusion. And it's caused by inflammation of the synovium, and it's usually preceded with a viral illness, a cough or a cold in the week or 2 previously. If it is the hip that is affected, the child will be holding it in a flexed, abducted position and tends to lie with it externally rotated, because this is the position in which the capsule is most lax and reduces the pressure. We always need to get X-ray, bloods, your CRP and your FBC. The CRP will be low, the white cell count will also be low, and the child won't have a temperature. And the ultrasound will often show an effusion. And the treatment for this is ibuprofen, anti-inflammatories, and it is self-limiting and will get better. Now that is in contrast to septic arthritis. So this is what we're always trying to exclude when we land on the diagnosis of transient synovitis. So septic arthritis is orthopaedic emergency because the bacteria that's within the joint causes damage to the cartilage within hours. And the most common bug is Staphylococcus aureus, and the most common joints affected are the hip or knee. And it's usually about 80% of cases, it's hematogenous spread from an upper respiratory tract infection. But we can have other things such as direct trauma, so an infected cut, sometimes an infected insect bite, or you can have an osteomyelitis, which is affecting the metaphysis and then enters the joint that way. Similarly to a transient synovitis, you're going to get an X-ray, you're going to get an ultrasound, and bloods, and always do blood cultures. Sometimes an MRI is also very helpful because it can tell us if there's any bony involvement of osteomyelitis as well. And the treatment for this is washout and IV antibiotics. So the child will need to go to theatre. The reason that this is an emergency is because the bacteria can cause damage to the cartilage, and you can see that this child had a septic hip as a baby, and now the femoral head is completely destroyed, as is the growth plate. Next, osteomyelitis. Now this can present similarly to a septic arthritis, and it usually occurs in the metaphyseal area of the bone, and that's due to the hairpin arrangement of the blood vessels, and the blood tends to slow down and become sluggish in these hairpin bends, and if you have a bacteria within your blood, it can stop and seed in this area. And you notice that this is very near the physis, and so we want to catch this early and try and prevent prevent progression of the infection towards the physis. Now, again, we're going to do an X-ray, but early osteomyelitis you might not see on an X-ray. We're going to do bloods, we're going to do blood cultures, and an MRI is really the most helpful instrument in diagnosis and guiding treatment. The reason why it also helps with treatment is children with osteomyelitis don't always need surgery. If it's a lesion just within the bone itself, we can treat that with antibiotics. But if it has formed an abscess between the bone and the periosteum, it's called a subperiosteal abscess, we like to drain that and then follow that with a course of antibiotics. I have an example here of a patient that I treated. On the left-hand side, she presented with a swollen forearm. There really wasn't much to see on the x-rays at all, but she was quite poorly, had a very high temperature and high CRP and white cell count. And you can see in the middle image an MRI scan, and all of that glowing white is a large subperiosteal abscess all the way around her ulna. So she needed to go to theatre and have that drained. And you can see her x-ray subsequently how that infection destroyed the bone. She did recover, but it you can see the caused a fracture. It doesn't look very healthy at all. This is another example of a child with a proximal tibia osteomyelitis. You can see that white glowing in the proximal tibia, and you can see that they've gone to theatre and they've had that abscess drained. And we also drilled the proximal tibia to release the pus from inside the bone as well. So if we go back to our flow chart for the younger child, we've gone down the painful arm of why a child might be limping. We've covered infection and inflammation. Now if we go down the painless arm, we come to developmental dysplasia of the hip, which we call DDH. So sometimes we can treat DDH as a baby. If it's picked up as an infant, we can treat it in something called a Pavlik harness. But if a dislocated hip is missed at birth, the child can present with a limp, which is painless when they start walking. Now, the treatment at this point, because it's later on, requires an operation, and we need to put the hip back into the socket. We can either do that just by what's called a close reduction, where we don't have to open the hip joint, or an open reduction. And that's when we have to do a bigger operation where we remove the soft tissue blocks to the hip getting into the socket. There's usually 4 or 5 things that get in the way. There's something called pulvinar in the socket, the ligamentum teres, a transverse acetabular ligament, and the hip capsule and the psoas tendon. Now, and once we've got that hip where it needs to sit, we put them in something called a hip spiker, which is like a plaster cast that looks like a pair of trousers. And you can see this baby is wearing one here. So DDH is a spectrum. It can be just a mild dysplasia where the socket is a bit shallow to a full-blown dislocation. And there's various risk factors for DDH. Females tend to get it. There can be a family history, breech presentation, firstborns, multiple births, and it's associated with oligohydramnios. Now, we don't universally give every baby that's born in this country an ultrasound. So we rely on an examination at birth where we do a test called Barlow's, which tries to dislocate the hip, or Ortolani's. If the hip is dislocated, we try to relocate it. Galeazzi's, which is looking at the leg length difference. And if the baby has asymmetrical abduction, sometimes the hip that is has the dysplasia doesn't abduct as much as the other side. Now, if a baby has a risk factor or a positive examination finding, we will do a ultrasound scan, and then we will make a decision based on that ultrasound scan whether they need treatment. Now, if we pick this up early, they can go into what's called a Pavlik harness. And this is what this baby is wearing here. If the baby presents later, after 6 months, it's too late to do an ultrasound scan and we have to do an x-ray. And that's when we're going down the road of a closed or open reduction, which we previously talked about. Along with the open reduction, we can do things such as osteotomies, where we change the orientation of the pelvis and orientation of the femur. This is a slightly busy diagram, but I wanted to show you how we draw some lines to help us know where the hip is sitting and whether it's in joint or out of joint. And I think that there's 3 important lines here that help. So the first one is called Shenton's line, which you may have heard of with fractured neck of femurs, but this is a line that's drawn up the medial aspect of the femoral neck and along towards the pelvis. And you can see that on the left hand side of the picture as you look at the screen, this is in a nice continuity, but you can see Shenton's line is broken on the right hand side because it doesn't, as you draw the line up the medial aspect of the femoral neck, it doesn't meet the line coming from the pelvis. Now the other important line is Hillgriner's line, which goes through the triradiate cartilage, and Perkins' line, which goes along the outside of the acetabulum. And the femoral head should sit in the inner bottom quarter of where those 2 lines intersect. And you can see on the dislocated hip on the right, as you look at the screen, it's in the upper outer quarter. So Shenton's line is broken and the hip is sitting in the wrong quarter of that, of where those 2 lines intersect. So sticking with our limping child, we are going up the age bracket slightly, age 3 to 12. We've still got the 2 arms of painless and painful. Like the younger child, we still have DDH in the painless arm, and we still have our infection on the painful and transient synovitis. We've just got 2 new possibilities to consider in the painful arm, Perthes and JIA. Perthes disease is a disease which causes fragmentation of the femoral head, and it goes through a remodeling process afterwards, but it can lead to loss of the shape of the head so that the ball and socket joint no longer fit together nicely, and you can have a square head in a round socket, and essentially the long-term outcome can be arthritis. So this tends to occur due to ischemia, and the damage to the blood supply causes necrosis of the femoral head. The mechanism and why it occurs, we don't fully understand. It's most common in boys between the ages of 5 to 10, and if the child presents with it younger, they tend to have a better outcome. And the X-ray can be normal in the beginning of the disease process. So an MRI can be helpful, but again, it's difficult to get MRIs if the child is not able to lie still, and they may require a general anaesthetic. There's a little bit of controversy as to how we treat this, and actually at the moment there is a randomized controlled trial called OP non-stop, where we are randomizing surgery, where we do a containment process, so put the head back inside the socket, against physiotherapy, and we will see what the results show. Still on that painful arm of children who are limping between the age of 3 and 12, though this can be the older child as well, is JIA, which stands for juvenile idiopathic arthritis. And it's a broad term that encompasses lots of different types of chronic arthritis that affect children. And it's really characterized by joint pain and inflammation. And it needs to be 1 or more joints that are involved for at least 6 weeks in patients less than 16 years of age. Symptoms can include a fever, or fevers that are spiking 1 or 2 times a day, morning stiffness and joint pain, and also joint pain and stiffness that comes on if you've been sitting for a long period of time, and sometimes it can affect the eyes as well, which is a sign of something called uveitis. But again, like the transient synovitis, we need to exclude infection. It's not usually something that orthopaedics manage, but we tend to perhaps see them first because we need to exclude infection. We refer to paediatrics, and they will likely do some clever blood tests looking for autoantibodies. And finally, the older child, both on the painless and painful side, we have slipped upper femoral epiphysis, and it tends to be painless when it's a stable chronic slip and painful when it's acute and unstable. And just to note, on the painful side, in the older child, we still have infection and we have JIA, which I just mentioned. Don't tend to get a transient synovitis in this age group. So SUFI, slipped upper femoral epiphysis. This tends to occur in adolescents around the ages of 11 to 15. Males are more commonly affected. They tend to be obese, and Afro-Caribbeans are also affected more commonly. Examination can actually, particularly if it is unstable, can present like an acute fracture. And they tend to, if it's unstable, they are not able to weight bear. And the child presents with the leg shortened and a little bit externally rotated. And if you try and flex the hip up, it won't flex right up. It tends to go into an externally rotated position. And the x-rays will show that it's like a Salter-Harris 1 fracture, really, through the growth plate. And the metaphysis shifts and the epiphysis stays in place. Now, this is urgent and it needs to be pinned. The metaphysis needs to be put back onto the epiphysis. There's different ways of doing it. We can either do it closed and just put a screw, pin it in situ with a screw. If it's a very large slip, it can be quite difficult to do, and there is a procedure called a surgical dislocation, but I think that's probably a little bit too much information for your stage at the moment. Right, moving away from the limping child to congenital deformities. So the most common congenital deformity that I treat in my practice is something called CTEV, which is congenital talipes equinovarus. And you may know this as called club foot. And this is diagnosed at birth. And the treatment for this has really been revolutionized by someone called Ponseti. And he has described a series of casting that we can start really from the age of about 2 weeks. And it's a series of casting which sequentially corrects the deformity. And after 6 weeks, 4 to 6 weeks, we tend to do a little tenotomy. We cut the Achilles tendon at the back of the ankle. And then after that, they go into something called boots and bars. You can see a picture of this baby wearing a pair of boots and bars here. And they wear those all the time for 3 months, and then just at night time and nap time until the age of 5. The reason why I say that Ponseti has really revolutionized the treatment of clubfoot, because before that these children were neglected, they were having multiple surgeries, and it's really a very simple way of treating the deformity. You can see this boy here has had his club feet neglected, and he's walking on the outside of his feet, and this will cause pressure sores. He won't be able to get shoes on. We can still try and treat this at this point with Ponseti casting, but likely they will be quite stiff. The other thing we see in children's orthopaedics is something called gena varum, which is bowed legs, or gena valgum, which is not knees. When we see this, we always want to know whether it is symmetrical or asymmetrical. You can see that the child on the right, as you look at the screen, has got significantly more gena valgum on her left leg than she does on her right leg. Now, This can be physiological. Children go through a stage of gena varum and then gena valgum as they grow, but it can also be pathological. It can be caused by vitamin D deficiency. There's something called Blount's disease, which affects the growth plate. So these are things that we always need to bear in mind. So vitamin D deficiency can cause rickets, and that can be either gena varum or gena valgum. It is rare, but we do see it in children's orthopaedics because we get referred the deformities, and then we investigate with blood tests. It presents really between 6 months to 3 years of age, and risk factors can be premature infants, Black or Asian children, particularly who are still breastfed, and also patients with malabsorption syndromes, and also a vegan and vegetarian diet puts you at a higher risk. Now, what happens is the low vitamin D levels lead to increased intestinal absorption of calcium, and then the low calcium leads to an increase in parathyroid hormone and bone reabsorption, and that's when we start to see the deformity. And then the blood test will show an increased alkaline phosphatase level. And a differential for rickets is non-accidental injury. And I'll show you some x-rays on the next slide. These are some x-rays of a child with severe rickets, and what you can see on the left-hand side of the slide is metaphyseal cupping, but this does resemble the metaphyseal corner fractures that we talked about right at the beginning of this lecture. And similarly, on the wrist views here, you can see this cupping quite clearly. The other presentation is something called rhaciotic rosary, and these are basically enlarged costochondral junctions of the ribs. And the reason why they're called rosary is that they resemble the rosary beads that you may have seen. So another jump of topic now to all conditions neuromuscular. So this is a big part of my practice and a particular interest. So neuromuscular, the term neuromuscular is a big umbrella for lots of different conditions. All of these children need an MDT approach with surgeons, orthopaedic surgeons, paediatricians, physios, occupational therapists, and they can have lots of other medical problems. So they may have a neurologist involved, a respiratory doctor, a gastro doctor. So there's a big team that looks after these children. From an orthopaedic point of view, I see them, they may have a scoliosis, so a curve in their spine. Their hips migrate out of joint, and they also have tight muscle contractures, though some are the opposite and very lax. And what conditions are we talking about? We're talking about Down syndrome, cerebral palsy, spina bifida, and muscular dystrophies. And there's different types of muscular dystrophies. We have Becker's, Duchenne's. Duchenne's muscular dystrophy is an X-linked recessive mutation which leads to the absence of dystrophin proteins. And how it affects the child is its progressive weakness, which affects the proximal muscles first, usually with their gluteals. And because of that, they get hypertrophy of their calf muscles, and the calf muscles are infiltrated with abnormal connective tissue. The reason why I see them often is because they get calf contractures, but they tend to need to be under a unit with cardiac support, because obviously they need the Duchenne's affects their heart as well. One of the signs of Duchenne's is something called Gower's sign, where because of their proximal muscle weakness, they get up from a sitting position using their hands to push on their legs to get up to standing. And this is to compensate for their weak gluteal, glute max and quadriceps weakness. These are some photographs and x-rays of a child with cerebral palsy. So the radiograph on the right shows the hip migrating out of the socket, and this happens because of the abnormal tension within or tone within the muscles. And we know that if we leave this hip to come out of joint, it will become painful. So we do an operation to put the hips back into joint. The bottom left photograph is a child that walks on her tiptoes with cerebral palsy, and it's not very energy efficient. So we quite often will lengthen either her calf muscle or her Achilles tendon. And the other thing that can happen is they can get these curves on their spine, a scoliosis, and this can also be a driving force for the hips coming out of socket, or the hips out of socket can drive the scoliosis. I don't do spinal operations, but my colleagues will do an operation to put rods in the back and straighten up the spine. And finally, children with Down syndrome. So when I see children with Down syndrome, they tend to have a different problem to the children with cerebral palsy. They tend to have low tone and ligamentous laxity. So just to recap, Down syndrome is caused by a maternal duplication of chromosome 21. The children tend to have a short stature, and when considering surgery on them, we also have to remember that they can have a C12 instability, so you need to be careful when intubating them. They tend to be under paediatricians. They can have delayed motor milestones and might walk a bit later, and I may see them because of their low tone. The hips will come out of their socket. The kneecaps can be unstable. They have what's called patellofemoral instability, and they can also get a scoliosis, and they tend to have flat feet. Because of the ligamentous laxity, they are more difficult to treat, and so need to be cautious with rushing into surgery, because we can put the hips back into joint, but they may come back out again. So that brings me to the last slide of the lecture. We've covered a really broad topic of conditions in quite a short period of time. I would expect that you may need to do a little bit of reading around some of the things that I've talked about, but I think my take-home message to you is that some of the conditions are urgent, and we need to recognise them and ensure that we get a diagnosis and treat them promptly, because they can have a lasting impact on this child's life if we don't deal with them properly. We always need to get a detailed history. Never forget NAI at the back of your mind. Sepsis needs to be picked up, and also a tumour can, as an orthopaedic surgeon, we do diagnose tumours and cancers. They can present as bone pain, so always think about that as well. So that concludes my whistle-stop tour of Paediatric Orthopaedics for the MLA. I hope you enjoyed listening.